All right, well, welcome everyone to another episode of Physician Father Interviews. Super excited today. I have Dr. Jason Vaught, and Dr. Jason Vaught has a really cool career that he's going to tell us more about. He is an assistant professor of obstetrics and gynecology at the Johns Hopkins Hospital. He is also a maternal fetal medicine specialist. He is the director of labor and delivery at the Johns Hopkins Hospital, and he's a surgical critical care clinician. So he wears all these really interesting hats that have built a really cool career, and I can't wait to hear more about it. So Dr. Vaught, thank you so much for chatting with us today.
Yeah, thank you for having me. I really appreciate being here.
No, it was super exciting to have you. You're someone I've wanted to have a chat with us for a long time because you have such an interesting career. So tell us a little bit about your medical journey. I mean, how did you decide on medicine and choose your specialty and your subspecialties and your training?
Yeah, so I pretty much started going into medical school thinking that I was going to actually do reproductive endocrinology and infertility. I think I froze. Sorry. I actually started off in medical school thinking I was going to do reproductive endocrinology and infertility. And I think that those physicians do some really amazing and great work. But really, when I actually had the rotation in it, it didn't really mesh well with me. I kind of wanted more of an excitement and more of a higher acuity of care. And that's really how I kind of fell in love with just like obstetrics and maternal fetal medicine, and even going the avenue of critical care. So that was really kind of like my trajectory. It was not like this like very well planned out like trajectory of like, oh, I'm definitely going to do this and I'm definitely going to do that. There were definitely a lot of, curvy roads along the way, but I'm very happy with where I'm at now and very happy with the possibility of a career trajectory that I have.
And did you know from the get-go you wanted to do obstetrics and gynecology, or what made you decide that first branch point?
Yeah, so actually, no. I actually thought I was going to do infectious disease. I really thought that I don't know if anyone remembers the movie Outbreak with Dustin Hoffman. I saw that movie and I thought I was going to be like Dustin Hoffman and like work for the CDC and fly all around the country. I mean, like, I guess it's like a modern day COVID, like a past day COVID-19 type story. But I really thought I was going to do ID, but I didn't. When I did my internal medicine rotation, when I did my ID rotation, it really wasn't something that I thought that I was interested in. But when I worked in OB, I really had great mentorship from a lot of really great physicians and clinicians. And then number two, I kind of found out that I really liked being around families. Like I really like not just being around like that one patient, but like being around the patient's family and being a part of like very critical parts of their life. I also like the fact that there was also kind of like this endpoint. I felt like with internal medicine, it was kind of like they were your patient and they were your patient forever. And that was great, I think, for some people. But for me, I kind of like, this is a 10-month long relationship. And like, this is a very critical point in your life. And I get to be around your family. And usually there's a good, if not semi-decent outcome. Don't get me wrong. There is certainly severe morbidity and even mortality in obstetrics and gynecology and high risk OB. But for the most part, the goal that you're working toward is a positive outcome.
Sure. And certainly maternal fetal medicine, one of the more common fellowships for an obstetrician or gynecologist. But what took you down the route to pursue surgical critical care?
Yeah, so that was one of the curvy road part of my life. So I said that, all the reasons why I went into OBGYN, and I had really great mentorship from an infertility specialist at my med school, which is University of Missouri, Kansas City. And he was like someone who had like actually like a great dad. Everyone loved him, a great surgeon. And he did a lot of really great things for people. And so for me, I was like, well, I want to be like this guy. I want to like be an infertility specialist and do that. And when I did my infertility rotation, I kind of found out that that was not the place for me or the career trajectory for me. So I was actually very stuck about what I was going to do next. I actually even considered leaving gynecology and obstetrics. And that all kind of happened when I was doing a critical care rotation. I was kind of figuring out what I was going to do next, and I found out how much I really loved critical care. And I was at this impasse of like, well, I'm going to leave OBGYN and do critical care through anesthesia or ER, or really go back to internal medicine and go through that route. But a really great mentor, critical care mentor that I still have today said, well, you know that you can be boarded through the American Board of Surgeons through obstetrics and gynecology. So I kept with that, thinking that I was just going to be like a private practice critical care guy. And then I really discovered, like, it was kind of like having that new knowledge. I would cover the L&D floor at the University of Florida. And I was like, I have to do academics. Like, there are so many different things that we can be doing as far as like sepsis and pregnancy and blood resuscitation and massive transfusion. It's kind of like I had all these new tools that I felt like I could bring back to the specialty. And the good thing was that was actually kind of already in vogue serendipitously. Like there was this big push in SMFM, or the Society of Maternal Fetal Medicine, that was called Bring the M Back in MFM, because maternal fetal medicine had gone so far fetal oriented, like just a lot of outpatient consultation, a lot of ultrasound. So what ended up happening is there was really nobody who was left to kind of take care of those women that had heart failure, that had placenta accreta spectrum, that had really bad kidney disease or chronic hypertension. And so it was actually perfect for me at that time to kind of decide that I really wanted to go back into obstetrics and maternal fetal medicine.
Wow. And so how do you split your time now in terms of your clinical practice? What's sort of your clinical breakdown?
Okay.
We froze a little bit. What's your clinical breakdown now in terms of how you spend your time?
Yeah, so I do about 6 to 8 weeks of critical care time a year. I cover every Monday on labor and delivery, and which is great. I mean, like, it helps me keep obstetric skills, surgical skills. I do a lot of the high risk sections and the placenta accreta spectrum. And I do at least one full day of clinic, half a day my own personal clinic, and the other half is what we call our fellowship clinic, which is really kind of like, I oversee the fellows, but we see like the heart failures in pregnancy, the placenta accretas, the really terrible renal disease in pregnancy in those clinics, and I get to staff that with them, which is a lot of fun.
Wow. And do you have any sort of handle for, I mean, it's such a unique pathway, you know, obstetrician, gynecologist, critical care physicians. Do you have any handle on how many of those there are in the country?
Yeah, so when I first started out, there was, I think, around 10 to 12 that were board certified through both MFM and critical care, but I'm really happy to say that the number is growing. Like, every time I go to a conference or someone else is like, oh, I'm in a fellowship, or I'm doing a combined fellowship. So I think it has to be at least up to 35 to 40. I mean, like, I would anticipate the way things are going, hopefully there'll be one at most major academic centers.
Even still, that's crazy. I mean, to say there are, 30 doctors like you in the entire country. I mean, that's pretty a pretty unique niche you've carved. I mean, it's really amazing.
Yeah, no, thank you.
And I can tell you that to me, was always readily apparent. I don't think we got to work together much in the ICU, but more than once, I was the anesthesia resident when you were the obstetrician on labor and delivery doing the surgeries and whatnot. And it was always a very sort of no BS, no drama environment. And that when I say it like that, it sounds very cold, but it was actually the complete opposite, because I think you were so comfortable with the acuity and the surgery and, dealing with critically ill patients, that it actually allowed for, I thought, a better sort of humanistic experience between mother, baby, et cetera, because in sort of the commotion of emergency sections that can happen, I think one of the biggest complaints from mothers is that, I felt so dehumanized, or felt like I was, just sort of a machine or an animal that people were operating on. And I feel confident that that's no one's intention, and everyone only wants what's best for mother and the baby. But again, I thought you were so skilled surgically and medically that the humanism was kind of allowed to remain there, because there wasn't as much excess commotion.
Yeah. Well, I definitely hope that's how it came across, and I can't guarantee every time it's like that. But yeah, I do try to pay attention to the fact that, even though this is an emergency situation, or even though this is a hemorrhage, our patients are still awake for the most part. You know what I mean? Like, and I think that's something that's very different from obstetric emergencies, that's different from other surgical emergencies, is that many times if the patient is awake, they will not be awake for that much longer. Usually there will be some, I mean, like some sort of induction of anesthesia. Whereas in our situation, sometimes the mother will stay awake, sometimes she won't stay awake. And also too, it's one of those situations where sometimes the partner comes to the OR, right? Or sometimes, the partner is right outside the OR, where I think that is also, I mean, of course, there's like waiting rooms and things like that in the GOR, but it's literally, they're right there. And so I really do try to keep an open line of communication and just say, this is what we're doing. This is what we see. This is the next surgical step. We're going to interventional radiology, or we're moving towards hysterectomy. I think hopefully patients receive that well.
Certainly seemed to be the case. I can tell you on the drapes we say, I think it was the case. So,
thanks, man. I appreciate that.
Such a cool career. And tell us a little bit about your fatherhood journey. Tell us about your family.
Yeah, so I actually met my wife, Kamaria, in med school. We've been together for a very long time, I think at least 12 years, not including marriage, but just like the whole spectrum of our relationship. We have a 19-month-old. We just have one, and he's just so amazing. I kind of always felt that I was like a very independent personality. But it's so fun having him, and it's so, like, even though I'm like, all these like things like critical care and L&D director, I most identify with being like Elias's dad. Like that is what like I think about constantly. That is what is like most important to me. And I always, everyone keeps saying that like, oh, it's a love that you will never know until you have it, and they're absolutely true. And I hope the best thing that I do is really raise a good son.
Sure. No, I think you're absolutely right. It's something you can't know until you know, and once you know it, it hits you pretty quick, and it is remarkable for sure. A very different kind of love. I mean, that's awesome. And so 19 months in now, what's your favorite part of being a dad?
Yeah, so my favorite part of being a dad is just watching him grow and watching him do all of the things that he's supposed to do, and I guess sometimes things that he's not supposed to do. But he's so inquisitive and ambitious, and I mean, like unrelenting. Like if he wants a book on the shelf, he will like climb all over you to get the book. And it's just great. It also, I think, where I hear some people say, "Oh, kids make your marriage worse," or I think it definitely has given me so much more appreciation for my wife and the time and input that she puts in our family, and how just like it makes me recognize how truly irreplaceable both of them are in my life. You know what I mean? So those like self and non-self actualizations have been really great for me.
Awesome. And what do you think is the most challenging part of being a dad?
For me, it's like knowing that I'm not going to be there, and it reminded me of like, so before, like when I was in residency in Atlanta, it was like, spring going into summer, and one of my buddies, he had Braves tickets, and he was like, oh, I want to have these Braves tickets for my job, whatever. He worked for like the park or the city or something. And I was like, yeah, I'll go. And he was like, oh, it's going to be on this day. And I said, well, let me check the schedule. And it was like a weekend, or it was like at night. It was not like during the day. You know what I mean? Like it was. And I was like, well, let me go check the schedule to see. And he like asked me, he was like, what would your life be like if you instinctively knew that you could make it all the time? If you instinctively knew on a Saturday or Sunday you could show up, or after 6 p.m. or 7 p.m. you could make it, what would that be like? And so that makes me think of like things for my son, and like kind of instinctively knowing that just due to call, administrative responsibilities, I may not be able to make everything, but definitely want to make most things. So that's probably for me the hardest, that realization.
And so how do you balance those two things, the time constraints that your many clinical hats place on you, and what's clearly the most important thing to you?
Yeah, so that's a good question, and I think I'm still learning how to balance it. I think one thing that I've kind of found out is knowing when you're needed in the hospital, and knowing when you're not needed, and knowing how to delegate. I think that's a task that I think having a child has really taught me, because at first I would be like, well, I want to be there for the patient, and I want to see the delivery, or I want to see the chest tube go in, or I like, you know what I mean? Like, whereas now you're like, okay, can I delegate this task?
Mhm.
And not only like, oh, just pushing it off, but is it safe for me to delegate? And also too, is it reasonable for me to delegate? So delegation has been a big part of it. And I think something that I've been using to balance, but also too, just being able to tell myself and to tell my patients, you know what, I'm not going to feel bad if I have a late start day and because I want to have breakfast with my son and our nanny. I'm not, or like, I'm not going to feel bad if like, when he starts playing sports and I'm like, I got to make this thing, like I'm going to leave at 4. So kind of reminding of myself that, I get to be human and you get to be a father and you get to enjoy those things as well.
Very cool. And, he's quite young now. I don't know if he's playing with stethoscopes yet or not. But if he says to you in, 10, 15 years, Dad, I think I want to go into medicine, what would you say to him?
Yeah. So, I mean, like, I'll be whatever he wants to do or whatever he wants to go into, I'm going to, fully support, I would say that I want him to really think about it. I want to say that he should do it if he really loves it. And I would say that, I'm very proud of you. I would, if he wanted any insight into what specialty would be great, I said retinal surgeon sounds amazing. But no, he should do whatever he wants to. Maybe he'll be like the ID doctor that I never was, or the infertility specialist that I never was, or maybe he'll do something totally different. But yeah, I would just support him in it. But I would just say, it's a big time commitment. And it's a big delayed gratification. It's a lot of delayed gratification. One thing that I would say is that I would say if he wants to change his mind, that's okay. I feel like a lot of like trainees and residents, they have this inner turmoil. Was this the right decision? Mm-hmm. But if you think of our friends like change their jobs every 2 years, and it's like not a big deal.
Right.
Like completely change their jobs. And not that I'm advocating for that, through the ACGME or anything like that. I'm definitely not advocating for that, but it's not like a unforgivable sin to do that.
Sure. No, that makes sense. And one of the things that I've been thinking about and having discussions with, and even trying to, build a little bit of an educational platform, and you're the perfect person to speak to about it, is, we're one of the wealthiest nations in the world, and yet our maternal fetal outcomes are abysmal.
Right.
And, I'm sure it is a very complex problem, but what is your sort of insight or opinion into that as to why that's the case, and where should our efforts be placed to make it not the case?
So I think a really big part of that is, as far as when it comes to severe maternal morbidity and mortality, is number one, access to care, and institutional biases, right? And I put it in 2 frameworks. So you have access to care that are issues for both people that live in inner city and urban populations, and then for also people that live in rural populations, right? So, and it's something that we don't really think about. So for instance, you could have someone who lives 2 blocks from Hopkins, which is one of the best hospitals in the world, but they can't get a clinic appointment. Right. You know what I mean? Like we say, oh, make a telemedicine appointment, but they don't have reliable Wi-Fi. They don't have internet access. They don't have a phone that is only theirs, or they're not in a space where they feel safe to like have a telemedicine visit. Right. And then also too, we have our rural communities where, just because you live out, 100 miles or 50 miles away from the nearest hospital doesn't mean that you can't get preeclampsia, doesn't mean that you can't hemorrhage, doesn't mean that you can't get an accreta. And so there are so many layers to that. And then there's the institutional biases that we have that are structured within our system, which is like, obviously just like a whole other talk. But I think it's like a multifold or a multimodal reason of why we have an increased morbidity and mortality. One other thing that I think that affects us that we don't often think about is not only the infrastructure of the insurance that we have, but the infrastructure of how we get data to look back at what could have been done better, right? So if you look at places that have universal healthcare, and this is not me pitching universal healthcare one way or the other, but there also is like a universal data set that those places can use, like the UK, the Netherlands being like one of the biggest examples of that. Where here, it's like, it's so hard to get like a granular data set to know what is working or to know what it's not working, because each hospital or each state may have its own system that it uses. And of course, there are like the large, like national inpatient sample databases, but you can't look for certain things.
Sure.
So there was one NIS sample that we looked for like opioid overdose, and it didn't have race. It was literally like, and so it's like, so how do you, research is not only a way just to get, publications and to like get promoted, but it really is a way to be like, oh, to say, how can we do what we've been doing, but better? How do we advance a career? How do we advance our specialties? I think that's like a lot of the reasons.
So do you think where a lot more of the effort needs to be put is both in terms of access and sort of changing the institutional biases that occur, as opposed to necessarily changing, the medicine, so to speak?
Yeah, so I think it depends. So I think that's also too like a thing of where I think what we change is so regional specific and maybe even institutional specific. Mm-hmm. You may be in a hospital that has has great outreach and great access to care to patients, but you actually don't have a really great blood bank. You know what I mean? Like, and there was actually like some New York studies that showed that women that were that had a higher risk of maternal mortality were more likely to go to hospitals that were not able to escalate to higher levels of care. You can be like this phenomenal doctor that has like a heart of gold that does not have a piece of bias of bone in your body, and we all have biases, but if you don't have the resources to take care of the patients, it matters, but you're kind of like dealt the short end of the stick. At another place, you may have all the resources in the world, but the institutional biases or the infrastructure may not be equipped to deal with, women and babies of color, women and babies that have migrated from other countries, things like that.
What do you think it is, or what do you think a woman could do, or the father of the baby, if they're involved in the care, as we're doing the Father's podcast, when they obtain care or they seek prenatal care or sort of peripartum care, what are the questions they should be asking to sort of, I guess, to advocate for themselves, to help position themselves most strongly to get the best care they can, other than saying, we'll go to this other hospital? What can they sort of do with any given circumstance they might be given, if that's an answerable question?
Yeah. So I think that's a really excellent question. And I think what I appreciate is when, families and women kind of set expectations, you know what I mean? Like, or when they do say, what is the infrastructure of the office? Like, you know what I mean? Like, am I going to see you every time? Am I going to see someone else every time? Like, or kind of realizing what their expectations are, I think is so important. I think also too, just keeping that method of just advocacy for yourself. Also, if you feel like something is wrong, or if you feel like something was not done that you may not think is to the standard, it's okay to bring it up. It's okay to come to your doctor's office and say, hey, this is what happened, and I'm a little concerned that it happened. Like, I actually appreciate and value those conversations.
Sure.
Because it's like, as a physician, it feels awful when you have been taking care of a patient and this has been like an ongoing issue, and like no one has ever said anything to you about it. I think also too, I think it's so important to look at the diversity within an office and within a practice, right? I think it's, and not just with like the physicians, but the nurses, if it's an academic center, through the residency program, through the techs, that's so important. I mean, like, don't get me wrong. I know that there are some counties that may not have the capabilities to be very diverse, but I mean, like, if I'm going to be honest, if you are seeking care in like Atlanta, Georgia, or in Baltimore, Maryland, and in the practice there, or Washington, D.C., there's not one physician of color that's like there within, not that you have to see that physician, you know what I mean? But like the fact that there's like no one, I would say, okay, so what's going on? Like, is this like an inclusive practice? Sure. So I think that's also like really important to look at.
And I think that actually brought me to something else I wanted to discuss with you, is that we still, there's such a lack of diversity in medicine and in medical training, and as such naturally carries all the way through, that you don't see the same level of diversity in the medical profession. And where do you think we can do better? Obviously we need to do better, but where do you think are some of the areas we can do better in that regard?
So I think one thing that we could do better is, making sure we are being inclusive from the jump and doing really targeted mentorship from the beginning of the medical school career. Like there's obviously an issue with enrollment, but there's also an issue with matriculation. There was an article that I think came out recently that said that a small percentage of Black men that enter med school actually graduate from medical school, and it's not based on the fact that they're not qualified. These are like qualified guys, like these are qualified women. So what is happening within the system where we're failing these people, or where we're failing us? And so I think mentorship is where it's at. Targeted mentorship is where it's at, to make sure and to really support, to support doctors like me, underrepresented minorities, like in medicine. So that's where I think that like would be a really big push. Also too, like I was a kid that went to, like at UT Memphis, a summer science camp, around the other like swim camps and basketball camps and things like that. But I think that's also a big push, like a community advocacy to get kids involved in science and math at an early age. And that's how it filters through.
Awesome. Well, you shared so much cool information with us today. Again, I really wanted to talk to you. I think you have such a fascinating career. Seem like a great guy and dad overall. So hope you have a very wonderful Monday and rest of the week. Thanks for chatting with us, and stay safe with all the patients you're taking care of. Thank you for everything you do every day.
You as well, man. Thank you for the invite. I really enjoyed myself.
Absolutely. Thanks so much. Have a good night.
All right, you too.